There we go. Okay, so melena, black tarry stools. So the upper GI, esophagus, stomach, and the first part of the small intestine, that's considered the upper GI. The lower two-thirds, the large intestine, rectum, colon, is the lower GI. So if you have bleeding, you have esophageal varices where you have these tortuous varicose veins, people get in the legs, they can get them in the esophagus. And if they burst, you're bleeding into the esophagus, which is going to go through the entire GI system. When you have bleeding in the upper GI, it goes through the entire system, and when it comes out, it turns into black, tarry stool. It has a very distinct smell to it, so if any of you have worked on the floors and you've been around a patient who has melena, it does smell very bad. So if you see melena, bleeding in the esophagus, stomach, or upper third of the small intestine, that's where it's coming from. Hematochezia, bright red blood in the stool. If it's bright red, that means it hasn't been in the system for very long, which means it had to come through the lower GI system. Lower GI tract, usually the colon or the rectum. Okay, hemorrhoids will present as bright red blood in the stool and also in the toilet when they go to the bathroom. That is a lower GI bleed. Those are very recent occurrences according to when the exit is of the GI system. Melena, upper, hematochezia, bright red blood is lower GI. Hematemesis is blood in the vomitus. Obviously, it's going to be from bleeding in the stomach or the esophagus in order for you to have vomit, blood in the vomit. So peptic acid disease. We're looking at the integrity of the GI tract. And there's a balance here. The balance is between the hostile factors, your acid, H. pylori, which is a bug, bacteria, NSAIDs, and pepsin. These are the hostile factors that they're going to reduce the effectiveness of that barrier. Okay, NSAIDs, they reduce prostaglandin production. Prostaglandin is the protective thing that goes in the mucus. That's why NSAIDs use lead to stomach issues, gastritis, because your hostile factors are winning out. Your protective factors, prostaglandins, and that's the link between NSAIDs and mucus problems. Mucus, bicarbonate, blood flow to the mucosa. These are protective mechanisms. They're going to provide that mucus layer, that alkaline layer that's in there to protect against the acid. So again, our stomach doesn't auto-digest itself. So excessive gastric acid secretion is only one factor when talking about peptic ulcer disease. We also have to talk about decreased mucosal defense, the lining, that our barrier we are damaging. So again, here is looking at the scales. As with everything in medicine, you're always looking at the risk and the benefits. What's the risk of using this drug? What's the benefit of using it? If someone already has issues with gastritis, they have stomach upset, acid reflux, and they're complaining of pain, are you going to give them an NSAID? No, because they already have a weakened protective mechanism. By giving them an NSAID, you're going to make it even worse. So things to start thinking about when you're prescribing medication. What do they have? What's going on? So peptic acid disease, acute or chronic gastritis. It can also be erosive as well. You can have an erosive gastritis. Acute is common, it's benign. The chronic form is associated with pernicious anemia. Okay, remember, B12, where does it start? What's the thing that starts the whole B12 process? Intrinsic factor, right? And where does intrinsic factor come from? The stomach. Now, if you're causing gastritis and you're ruining that lining of the stomach from this excessive acid production and you're ruining the defenses, you're going to have a problem with secretion of that intrinsic factor. If you're not secreting intrinsic factor from the stomach, there's no B12 to absorb at the other end. And that's the link between gastritis and pernicious anemia. Again, this is not going to happen in 3 months. This is a chronic gastritis, long time. Also, risk factor for gastric carcinomas with these chronic gastritis. Acute or chronic ulcer disease can develop from prior gastritis. So gastritis is just an irritation of the lining of the stomach. Okay, nothing to do with ulcerations or anything. Chronic ulcer disease can come from that chronic gastritis though. So peptic acid disease, gastritis. This is gastritis. Do you see all that irritation right there? It doesn't look like that clean tissue over there, but you see all these dots and the little pits everywhere? That is the that is the gastritis. Irritation of that line messes up that nice clean line of the stomach lining. You're going to have problems with, obviously, secretion from that. Chronic atrophic gastritis. This is almost also a partly autoimmune. It has these autoantibodies to the parietal cells, intrinsic factor, and gastrin are present. We get inflammatory cell infiltration. Okay, we have an inflammatory process. We need to repair that. So we're going to have the inflammation itself causes this issue to happen. Muscle atrophy, that's why it's called atrophic gastritis. And loss of glands. If you lose your glands in the stomach, what is going to be reduced? Digestion, acid, all that fun stuff. So capacity to secrete gastric acids is now reduced. Serum levels of gastrin are increased. What is the purpose of gastrin? To release hydrochloric acid. Remember, get that gastric acids going. What shuts it off is gastric acid as well. But we don't have the gastric acid because we have gastritis. So the gastrin is going to keep going. Okay? When you have all this gastrin, other things start causing problems too. So those gastrin levels go up, and there's your gastric ulcer. Also, intestinal metaplasia, and whenever you see metaplasia, the risk of cancer goes up as well. Peptic acid disease is also associated with H. pylori, pernicious anemia, gastric adenocarcinoma, and GI endocrine hyperplasia. Why are they getting GI endocrine hyperplasia? What hormone did I say is going to be increased in concentration? Gastrin. If I need to increase my gastrin and I need more of it, those gastric glands are going to hypertrophy in order to secrete more gastrin. Because think of it like your thyroid. If you have, we have low levels of TSH, so nothing, or low levels of your thyroid. So your thyroid's not working, it's not producing any T4 or T3. That negative feedback is not there to turn off your hypothalamus and the pituitary gland. So what are they going to be constantly secreting? TSH. What's going to happen to that thyroid gland by all this bombardment of TSH over time and the production T4, T3? Especially in hyperthyroidism, the need for thyroid hormone goes up, the gland gets bigger. So whenever you need more of a hormone, that gland sometimes can get bigger. So here is a look of, here's normal gastric mucosa, and this is your chronic atrophic gastritis. Much paler looking, doesn't look as wet, looks a little bit drier. Why would it look drier? Doesn't have as much mucosal stuff anymore. The barrier is gone, and you have this chronic atrophic gastritis. So peptic acid disease, the complication of chronic atrophic gastritis, in summary, impaired vitamin B12, due to loss of your intrinsic factor. When we talk about ulcers, it's very important to know where the ulcer is. There's two locations ulcers can form. In the stomach, and it's called a gastric ulcer, or the ulcer can also form in the duodenum. That's called a duodenal ulcer. Why do you think you would get an ulcer in the duodenum? Gastric acid getting into the duodenum. If we're having too much gastric acid, that gastric acid can get into the duodenum. And just like in the esophagus, the duodenum is not made for high acidic environments. That's why the sphincter of Oddi is right there. to dump in the alkaline pancreatic juices to neutralize it. So the ulcer can form in the duodenum or the gastric tissue. The key comes in with their presentation. When does the pain occur? So let's talk about gastric ulcers. Chronic, mild, gnawing or burning abdominal or chest pain. So they're going to have ulcer burning pain. Obviously, that makes sense. Could be from superficial or deep erosion of that GI mucosa. So this next part is the very important part. Pain intensifies with food ingestion. So they're going to say, I ate lunch and like a half hour later, I got really bad pain. If they already have a gastric ulcer, why would their pain go up immediately after eating? Acid secretion is going to go up because we're eating food. We want to digest that food. Stomach stretch happens. Gastrin comes out. Hydrochloric acid goes up. But we already have an ulcer there. So all that extra gastric acid irritates the ulcer. It's like putting lemon on a cut. It burns. That's what's happening with a gastric ulcer. And because when they eat, it causes them a lot of pain afterwards, they avoid eating. And they start losing weight with gastric ulcers. Okay? Because whenever they eat, acid goes up, irritates the ulcer, causing pain. They don't like it, so they kind of avoid food. A duodenal ulcer, same symptoms, 1 to 3 hours after eating is when this one occurs. Why does this occur 1 to 3 hours after eating? The food's got to sit in the stomach for a few hours to digest, get broken up, before it leaves. And when it leaves, a couple hours later, that acidic chyme hits the duodenum where you have that ulcer, and then that ulcer gets hit and doesn't like it and causes pain. So because of that, it can wake them up at night. You eat something, a late dinner, you go to bed, 2 hours later, you wake up with indigestion, a pain in the belly and all that stuff. That could be due to a duodenal ulcer because the pain happens 2 or 3 hours later. Antacids or food intake provide relief. So when they do eat, it helps with the pain. When they eat and the stomach starts to stretch, what does the stomach do? Does it prevent food from leaving it or allow food to leave the stomach and get to the duodenum? It prevents it. You got to hold the food in the stomach to break it down and digest it. So if I eat food, the food's not leaving the stomach as much. The sphincters close up and the pyloric sphincter stays closed. The food stays in there. So less acidic chyme leaves the stomach and irritates the duodenum when you eat. Yes?
Do you think like if they chew gum and trigger your stomach to think there's food coming in, that will also provide?
Not chewing gum. There's nothing. The relief comes from the stomach stretch, and there's got to be food or liquid, something going in there. So they often gain weight with a duodenal ulcer because they want to eat to avoid the pain. Yes.
Do antacids not also help with gastric ulcers, and why not?
It does. They're going to need more of. They need to actually repair that ulcer. It takes a while. You got to really relax that stomach. Okay. So, etiology of GI ulcers. H. pylori is the big one. We'll talk about that in a little bit. How H. pylori can cause all this problem. It's just a bacteria, but it does a lot of stuff in the stomach. NSAIDs we know, alcohol abuse we know, shock, uremia, burns patients get stress ulcers, and hypersecretion of gastric acid, gastrinoma. That was a question on your physio exam, a thinking question. So you have a gastrinoma that's continuously secreting gastrin. What's going to happen to your hydrochloric acid? It's going to go up. Okay. Okay, let's talk about H. pylori. This is what it looks like. Okay. Corrosive agents secreted by the stomach obviously play a role. Common themes, again, excessive acid secretion or you're reducing your defense. Those are the ways you weaken or strengthen your stomach wall lining. Unclear why one form of the disease starts in some people versus the other form, meaning is it a weakened protection or excessive acid, but infection with the Helicobacter pylori will accelerate mucosal damage. And this is just a good summary slide, kind of talking about looking at your mucosal barrier protection and your acid. And those are all the things that contribute to increased acid secretion and what things contribute to a weakened defense. This is a good summary slide for that. So gastric ulcer differs from erosive gastritis because of the depth of the lesion. Gastric ulcers penetrate through the mucosa. Gastritis is just a superficial layer of the stomach. Doesn't really get into the mucosal too much. Possible contributory factors, motility defects. So they get reflux of the duodenum contents, the bile acids come back up into the stomach. Mucosal ischemia may also present. Again, if you're ruining the defense, the barrier, you make the acid stronger. Duodenal ulcers are more common than gastric, may be a genetic component. So ask anyone in your family also have ulcers. Caused by altered mucosal response, acid, and stress. Psychological stress can cause ulcers. It's also a sequelae of H. pylori. Less association with gastric adenocarcinomas when you have a duodenal ulcer compared to those gastric ulcers. Duodenals won't cause it as much. And here's the difference between a duodenal ulcer. You can see here the bottom picture tells you where the scope is in relation to the anatomy for the endoscopy. Okay, so this is your duodenal ulcer, and there's your gastric ulcer. Yes?
Will these ulcers go away on their own over time?
If treated, yes.
Okay, treated.
So complications, look at that squirting ulcer. What layer did that ulcer have to penetrate into? Submucosa. That is where the blood supply is. So you know how deep that ulcer had to go to get that squirting like that. Complications, again, acute or chronic GI bleeding. Obviously, if you have this going on, you're going to be losing a lot of blood into your GI system. You may become anemic and a lot of problems. Hematemesis makes sense. Hematochezia, melena. Life-threatening perforation or obstruction. If that perforates, and now again, you have an open GI material going into your abdominal cavity, you're going to go septic really, really fast. Gastric outlet obstruction, if something is preventing the bolus of food from leaving the stomach, it's going to remain in the stomach. Acid's going to be built up. More acid, more chance of getting an ulcer. So you can see here in the different layers, here is the gastric mucosa. We're starting to damage the mucosal. H. pylori is the big one. You can see the mucosal layer is getting thinner and thinner, and then when you get to the end there's no more mucosa, or mucus. It's all been taken away. Here's our mucosal layer. Okay, chronic gastritis does not enter that mucosal layer. It stays in the mucus. We get some inflammatory properties. There is some inflammation going on. So those cells are there, but it hasn't invaded the submucosal space. Now, peptic ulceration. Look how deep we went. We went right through that barrier, muscularis mucosa, and now we're in that submucosal layer, and that's why they have the bleeding. So if they went into that submucosal layer, they're going to have these bleeding ulcers. So H. pylori, common pathogen, over half the world's population is exposed, obviously higher in areas with poor hygiene and sanitation. Person to person is likely fecal oral, and the water may be that reservoir for the transmission. If you look at it under endoscopy, gastritis or duodenitis, but they may be asymptomatic. Only 15% of people infected with H. pylori will develop a clinically significant ulcer due to the H. pylori. And there's genetic factors here. There's smoking again. Doesn't do very, very good things for us in the GI system. Highly associated with the development of gastric carcinoma. So here we have another bug, or a bug, the first one, that can lead to a cancer diagnosis, H. pylori. So what is going on with H. pylori? What does it do that makes H. pylori so effective? There's a couple of things. One, it moves in a corkscrew fashion, so it burrows itself into the wall. It can get through that mucosal layer. So it buries itself right through the wall, gets in there. Okay, attaches to adhesion molecules on the surface of the cells. In the duodenum, it only attaches to areas containing gastric epithelial cells. Remember, the cell type matters. If you have a duodenal ulcer, that means that some of that tissue had to have changed to more of a gastric type of tissue. That is what H. pylori will attach to. And if in the duodenum you already have this tissue metaplasia occurring, H. pylori can get there and go in the duodenum and attach itself to those type of cells. It can live in such a hostile environment because it produces urease. And what urease does, it converts urea to ammonia. So it's got this little cloud around it. And that has this little ammonia cloud. What does this ammonia do that makes it so helpful? Buffers the hydrogen ion. So the acidity will not kill the H. pylori because it has a little protective cloud around it. This alkaline cloud protects it from the acidic environment of the stomach, and it can corkscrew its way in and get into the wall and start causing problems. So that's how it gets there. Now, when it's there, urease, because that's what it's secreted by the H. pylori, creates a very strong immune response. Okay? Ammonia hydroxide produced by the urease damages the gastric epithelium and allows the H. pylori to survive. H. pylori then starts releasing endotoxins, lipase, proteases, which further degrade the gastric mucosa. So we are weakening the defense of our stomach. We're not increasing the acid. It's the defense. H. pylori attacks the defense. Okay. Cytotoxicity of H. pylori has also been seen with two other proteins, CAG-A and VAC-A. Don't worry about those ones so much. But again, here's a great summary slide of the H. pylori. It attaches itself to the host cell, gastric cell only. Has urease, that little cloud that protects it. Has an ammonia, that alkaline cloud that protects it from the gastric acid. Allows it to get into the wall where it starts releasing all of those toxins. And here's another summary slide for you with regards to your H. pylori. So some outcomes with Helicobacter pylori infections. 80% asymptomatic, or they have just some chronic gastritis for the majority of them. 15 to 20% will have metaplasia or even develop those gastric or duodenal ulcers. Less than 1% go to the cancer, and that's what MALT is, mucosa-associated lymph tissue, MALT. Okay, they get infected with the H. pylori, and less than 1% of those patients will develop this type of cancer. So there's that link between H. pylori and a cancer. NSAIDs, okay, small percentage of patients who have adverse GI events associated with NSAIDs that will result in substantial morbidity and mortality. When we keep talking about NSAIDs and all these other things, the majority of people can still take NSAIDs and be fine. But if you know you have a patient who already has kidney problems, don't give them NSAIDs. If you know they already have gastritis or some acid problems, don't give them NSAIDs. But if they don't have any of these underlying problems, they're not going to have an issue with taking NSAIDs. However, this NSAID-associated gastric and duodenal ulcers can be associated with advanced age. So elderly people taking NSAIDs can develop gastritis easier. History of a previous disease, ulcers. Concomitant use of corticosteroids or anticoagulants can also lead to NSAID-associated gastric ulcers. High doses of NSAIDs, okay, you can overdose on these things. Gotta be very, very careful. Those of you who worked at the Disney runs, usually they put the X's on the hands to show they've already gotten a dose. Usually it's Tylenol there, but still you can overdose on these things. So they'll put marks on their hands so they've already gotten a dose that you have to be careful. So what does it do? NSAIDs mess up the gastric mucus. It's the protective mechanism, and NSAIDs affect that. Okay, NSAIDs decrease synthesis of mucosal prostaglandins. Okay, that's what's going on. It inhibits the prostaglandins, and they're the help with the protective part of our mucosal barrier. The precursor of prostaglandins is arachidonic acid. That undergoes two enzymes, COX-1 or COX-2, to give you other benefits. The reason we give NSAIDs, and I think this is the picture right here. So here's your arachidonic acid, COX-1 and COX-2. COX-1 leads to prostaglandins, protect gastric mucosa. COX-2 is the inducible prostaglandins as well, but these are moderate pain, inflammation, and fever. And that's what we give NSAIDs a lot for, is to block this. We don't want you to have the fever and the pain and all that stuff. So that's why NSAIDs work. The problem is that when it does induce these things, the prostaglandin concentration goes down, which over chronic use, not just taking it for 2 days. This is people who take it chronically 4 times a day, every day because of osteoarthritis or whatever. And now you start complaining of stomach pain, stop the NSAID. That's what's causing it. Once you stop it, give them some time, it should come back to normal. They'll be okay. Gastritis in people with NSAIDs appears to be more due to H. pylori, though, not so much the NSAID use. And NSAIDs are most likely to cause gastric ulcers than duodenal. And again, main thing with NSAIDs, inhibition of prostaglandin synthesis. We're not making the prostaglandins. They need to be present in that mucus to help with the barrier, and they're not there anymore. So here's your summary slide on peptic ulcer disease, and then we're done for the day. And we'll do the rest on Monday.